Hey everyone, today we'll be discussing about Graves' disease. So Graves' disease is a hyperthyroidism disorder. Okay, so in these cases, the ratio of female is to male ratio that is more than 10 is to 1, that is 10 is to 1. So okay, and it occurs in 20 to 50 years of age. Okay, genetic factor, there is involvement of HLA-DR, there is involvement of CTLA4, and then there is involvement of PTPN22, and there is involvement of TSR genes. Okay, so there is normally there is involvement of two things, that is genetic factor and the environmental factor. Okay, genetic factor, there is involvement of the HLA-DR, CTLA4, PTPN22, and then TSR genes. Okay, in environmental stress, what happens? There are two things. Okay, there are two things that play in the roles. Okay, so they are the stress. Okay, stress, smoking, increase iodine intake, postpartum. So, okay, and then there is after HIV, after HART. Okay, that is the things over here. So what is the normal physiology environmental? You can see over here: stress, smoking, increase iodine intake, postpartum, HIV after HART. Okay, so what is the pathophysiology behind these things? Okay, so what happens? There is production of the autoantibodies. What are the autoantibodies? There are three autoantibodies. They are TSI, anti-TPO, and the anti-thyroglobulins. Okay, so this, as a result, what happens? This could not act over here. Okay, this could not act over here, and this could not act over here. So what happens? This TSI goes and inhibit TSHR receptor. Okay, and TPO goes and block thyroperoxidase enzyme, and this thyroglobulins and the thyroglobulins, this blocks this stop the thyroglobulins. As a result, what happens? There is TSS production less. Okay, also there is less production of TPO, also there is less production of thyroglobulins. Okay, as a result, as a compensated mechanism, there is increase in the level of 34. So now we can describe these things graphically. So it is composed of hyperthyroidism features. Okay, it composed of what? It composed of hyperthyroidism features. Okay, and then there is also inflammatory process going on. Okay, so now you can see over here. Okay, inflammatory process will be going on. So as a result, what happens? There is cytokines, EOM infiltrated by extraocular muscles infiltrated by T cells. Okay, there is interferon gamma, TNF, and interleukin 1. This all release take place. Okay, there is also activations of fibroblast. This interleukin 1 gives fibroblast activations. As a result, what happens? There is formation of there is activation of increased synthesis of glycosaminoglycanins. Okay, glycans. Okay, glycosaminoglycans. Okay, so now this will be deposited in different part of the body. Okay, so this is the things. Okay, just to revise it again. So there is TSI. There are three antibody. This is TSI. Okay, and anti-TPO and anti-thyroglobulins. Okay, thyroglobulins, and then this destruct this part, and as a result, there is less amount of this TSS. Okay, as a result, compensatory there will increase in the level of T3 T4. Okay, so cytokines, and then as a result also this T3 T4 increase will be there. Also there will be cytokines release, and these cytokines goes and act on the extraocular muscles. Okay, that is infiltrated by T cells. Also there is interferon gamma, TNF, interleukin 1, fibroblast release, fibroblast activation take place. As a result, there is activation, there is release of GAG, that means glycosaminoglycans, and is deposited in different part of the body. So what are the clinical features? Okay, so this depends on the severity, duration, and the age. Okay, individual response to excess thyroid hormone. Okay, so how the individual response to excess thyroid hormones, that depends on the clinical features. Okay, so hepatic thyrotoxicosis, fatigue, weight loss. Okay, so hepatic will be there. What happens? There is fatigue and weight loss. Okay, and symptoms of thyrotoxicosis, there is gynecological involvement, OFS involvement, there is severe involvement, lethargy, weight loss. Okay, so what is the things? So specific to Graves' disease, there are ophthalmopathy. Okay, that is unilateral. Okay, and 75% case after 1 year. Okay, and then what happens? You can see over here, and then we can see earliest symptoms. Okay, so gritty sensation of eye discomfort, excess tearing, severe cases, corneal damage, chemosis, diplopia, optic nerve compressions. Okay, so these are the features. Okay, these are the feature of what? These are the feature of ophthalmopathy. Okay, these are the feature of ophthalmopathy. Also there is proptosis and the lid retractions. Okay, in dermopathy, what happens? There is anterior and lateral aspects involvement. Okay, this glycosaminoglycans goes and deposit in the disc part. As a result, there is peripheral myxedema. Okay, there is also orange skin appearance. Okay, and then there is acropathy, there is cloving, of the patients. Okay, strongly associated with dermatopathy. Okay, and now is the result. We discuss about three things, that dermatopathy, okay, ophthalmopathy, and the acropathy. Okay, and then now we will be talking about lab evaluations. Okay, so there is increase in the level of T3 T4. Okay, and T4 toxicosis will be there. T3 T4 toxicosis will be there. So okay, so how we can evaluate the case. Okay, so TSS unbound T4. Okay, we can evaluate the case. Okay, so we can differentiate it from next part over here. So T3 T4 TSS unbound T4. Okay, so if TSS level decreases, unbound T4 high, that is primary thyrotoxicosis. Okay, feature of Graves' disease, yes and no. Okay, there might be yes or no, but in if the TSS low, unbound T4 normal, measured unbound T3 high, and soft clinical hypothyroidism follow up in the 6 to 12 weeks. Okay, so this is the things we have to diagnose. This is the things how we can diagnose the case of this Graves' disease. Okay, so you can see over here, this is the approach over here. So if the TSS is low, unbound T4 high, that is primary thyrotoxicosis. Okay, but if the TSS low, unbound T4 normal, that is measured unbound T3 high. So if high, okay, leave it. Okay, now it might be a case, but if soft clinical hypothyroidism, follow up in 6 to 12 weeks. Okay, and TSS receptor normal or increase, different things, different part. Okay, and then different part over here. And then if the TSS and then on bound T4 normal, okay, that is different part over here. Okay, so these things, so same things, TSS normal, unbound T4 high, primary thyrotoxicosis, T3 toxicosis, feature of Graves' disease, yes or no. So if yes, that is Graves' disease. If no, that is multinodular goiter. Okay, so now if multinodular goiter, that is yes, toxic nodular goiter. If no, then radio low radio, that is low radio and nucleotide uptake. Okay, so we will need to bring these things. Okay, if there is uptake of radionucleotide, then what have, yes, that is destructive thyroiditis. Okay, if no, rule out other causes. Okay, so this is the things over here. We approach the case. Okay, so TSS normal increase, we leave it. If TSS and unbound T4 normal, we leave it. Okay, if TSS decrease, unbound T4 high less. Okay, unbound T4 high, that means we have to do survey for primary thyrotoxicosis. It is primary thyrotoxicosis or due to multinodular goiter or this Graves' disease. Okay, we have to differentiate that things. Okay, and we'll investigate furthermore. Okay, this is the things, and then we'll treat the case. How we can treat the case? We have to give beta blocker or propranolol, that is 20 to 40 mg per 6 hour. Okay, and then we have to give decreased thyroid hormone synthesis inhibitor. We have to give decreased thyroid hormone synthesis. So as a result, we have to give antithyroid drugs. Okay, the same thing, antithyroid drugs are okay. Methimazoles, carbimazoles. Okay, these are the drugs. Okay, carbimazoles. Okay, and propyl thiouracils. Also, we can do radio iodine ablations. Okay, also we can give I-131 capsules. Okay, that is the things of radio iodine ablations. Okay, and then we can do surgery. So in surgery, we can do subtotal thyroidectomy, adjunctive therapies, oral radio contrast agents. Okay, glucocorticoids, cholestyramine, lithium. Okay, so these are the things we can give. Oral radio contrast agents, we can give glucocorticoids, cholestyramine, lithiums. Okay, so treatment of Graves' ophthalmopathy. Okay, so how we can treat, because there are complications related to it. Okay, so reversal of the hyperthyroidism, smoking cessations, eye tears, drugs, selenium. Okay, these are the things. And then dermatopathy we can treat with the help of intralesional triamcinolone. Okay, so let us revise lastly. So Graves' disease is a hyperthyroidism disorder. Okay, so it is composed of hyperthyroidism features. Okay, and it involves most in 40 years of age, more in female. Okay, and then we talk about the autoantibodies. There are 3 autoantibodies. Okay, anti-TPO, anti-thyroglobulins, and TSI. Okay, and this causes increase in level of T3 T4. Okay, this is causing thyrotoxicosis over here. This thyrotoxic feature will be causing 3 things, that is dermatopathy, ophthalmopathy, and then what, then there is pretrivial macular edema. Okay, see the thing, in ophthalmopathy we can see proptosis, lid reaction, and different things, and then proptosis, and then we have dermatopathy. Okay, and then acropathy. Okay, these are the 3 things. And then what happens, clinical features, and then we'll investigate the case. So we'll be looking for unbound T3 T4. Okay, and then TSS. Okay, if there is TSS high or low, we'll be comparing the case. Okay, we'll be investigation with this, and we'll be confirming, we'll be revising, we'll be repeating the investigations furthermore in 3 to 6 weeks. Okay, and then we'll be treating the case. In treating the case, we have to give beta blocker, and then we will be giving antithyroid drug. We can also perform surgery. We can do subtotal thyroidectomy. Okay, and then we can do total thyroidectomy. Okay, depends on the situations, and then we can treat the complications. Okay, we can treat the dermatopathy, we can treat the this ophthalmopathy. Okay, in this way we completed Graves' disease. Okay, thank you.